Good afternoon, and thank you for joining the RLS Foundation's webinar titled Current Investigational Therapies in the Treatment of RLS. My name is Adriana Colucci, and I'm the Communications Coordinator for the RLS Foundation. The 2025 Educational Webinar Series is an official RLS Foundation program aimed at addressing integral topics relevant to the restless leg syndrome community through monthly expert-led webinars. The RLS Foundation is using Zoom for this program. To ensure a seamless viewing experience, confirm that your Zoom Workspace app or browser software is up to date to meet Zoom requirements. Following the live webinar, the recording will be made available for active members to view through their online member portal. If you would like to view webinar recordings and you are not a Foundation member, we invite you to join online today by visiting www.rls.org. Please be aware that all attendees will remain on mute during this hour. Following the slideshow presentation, the speaker will answer as many pre-submitted audience questions as time allows. As always, individuals suspecting they may have RLS should consult a qualified healthcare provider. The information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a physician. For help accessing the live webinar on your computer, call the office phone number listed on your registration confirmation email. For additional questions about this program and future webinar events, you can email info@rls.org or visit www.rls.org. Our speaker today is Dr. Andy Berkowski. Dr. Berkowski is an RLS expert and sleep specialist at Relax Health, a direct specialty care clinic specializing in telemedicine care of RLS and complex sleep disorders. Before completing training in adult neurology and sleep medicine, Dr. Berkowski earned his bachelor's degree in religious studies at Stanford University before returning to his home state of Michigan to study medicine, where he graduated from Wayne State University School of Medicine. He then completed a transitional year internship at Henry Ford Hospital and neurology residency at the Detroit Medical Center / Wayne State University, and completed his fellowship training in sleep medicine at the Stanford University Medical Center. He spent 7 years in academic medicine, including as faculty at the University of Michigan and Cleveland Clinic, before founding Relax Health in 2022. He is a fellow of the American Academy of Sleep Medicine and is vice chair of its Clinical Practice Guidelines Task Force for the Treatment of RLS, which was just published in print on January 1st of this year. Dr. Berkowski also serves on the Foundation's Scientific, Medical, and Advisory Board, the Brain Bank Committee, and writes the In the News column for Nightwalkers. Thank you, Dr. Berkowski, for sharing your time and expertise with us today. I now invite you to begin your presentation.
Well, thank you for that introduction, Adriana. We had a lot of difficulty coming up with this title because the terminology is so confusing. So hopefully we can go through it. The copyright notice for this lecture, not to take screenshots of these slides and distribute them or sell them or post them or do anything with them. So this is the copyright notice. The other important thing is I have no conflicts of interest or financial disclosures or anything. So the information I'm presenting is based on research, and I'm calling it like I see it. I'm not financially biased. Everybody's biased, but I'm not biased due to financial interests or conflicts of interest. So your first question, and one of the reasons we had a hard time coming up with the title of this, and even, if you look at the material, we had different titles in the material, but we didn't know what to call it. But what's an investigational? What does off-label mean? What does experimental mean? FDA approved, but what if it's FDA cleared? What do these things mean? And to be honest with you, I didn't know exactly what all of these meant either, so I had to actually look up some of this stuff. But let's start with FDA approved. For FDA approval, there's a rigorous set of steps that a new drug needs to take, and it's approved for an indication. So it's not just approved in general, it's approved for a specific condition. So approved for restless leg syndrome, that would be FDA approved. Now, what does investigational mean? It also means experimental. So it's basically the same thing. So there's two ways it could be investigational. Number one is the treatment could be not FDA approved yet, but it could be approved for testing in individuals, which are called phase 3 trials. We'll see one of those drugs later. The second type of investigational drug is a drug that's FDA approved for one condition, but it's being tested in others. And I don't know if any of the ones I'm presenting today actually meet this classification under the FDA, because a lot of times companies don't get a second approval or for a second indication, but that's what these terminologies technically mean according to the FDA. Off-label, so it's approved by the FDA for one condition, but used for another. So the best example of this is gabapentin. Gabapentin is a consensus first-line treatment for restless leg syndrome. It's one of the top 10 prescribed drugs in the US. I just looked this up. And it's actually FDA approved for shingles and seizures. And guess what it's used for? Not shingles and seizures. It's almost never used for seizures, and there are other drugs that work better for shingles. So gabapentin is one of the top 10 drugs in the US, and it's not used for what it's approved for. And the fact is, up to 20% of all prescriptions are for drugs that are off-label, and 50% in cancer treatment. Like, it works for one type of cancer, it's used for another. So this is actually not something to worry about that much, because it's already gone through FDA approval, the safety and everything is there. But just because it's used for another condition, that's kind of the hallmark of American medicine. And in restless leg syndrome, nearly all restless legs treatments are not FDA approved. In fact, there's only one that we still recommend that is FDA approved, that is gabapentin and acarbol. And in the 2025 AASM guidelines, which we'll hit in a couple slides here, that's the only recommended drug. And 3 of the 4 FDA approved drugs for restless leg syndrome are not recommended. So does the FDA approval mean much in this case? No, it really means almost nothing at this point. So then there's FDA cleared. So this usually refers to devices, and we'll talk about one of them shortly. Low to moderate risk devices have to be cleared by the FDA. So the perineal nerve stimulator is one of these that's been FDA cleared. So it doesn't have to go through the rigorous approval of a drug in a phase 3 or the approval of a device that's more dangerous, but it does go through some approval process, but the bar is much lower. So you have to be careful with FDA cleared devices because it's more of a safety thing that they're safe, but it doesn't always mean that they're effective if it's FDA cleared. So the aforementioned American Academy of Sleep Medicine, we published the clinical practice guidelines they came out on the web in October, but the print version was published on January 1st. So no better way to start the new year out than a completely new paradigm for the management of restless leg syndrome. I encourage everyone watching this video with an interest in this topic to read the guidelines, because I can guarantee you most of the physicians and providers in this country have not read the guidelines, and they're going to be spinal cord shocking to most people who aren't aware of the changes for this condition. And so the point of the guidelines was to develop in people with somebody with new restless legs, what are the treatment options that are the most effective? And it weighs the balance of effects. So the risks, the adverse effects versus the strength of the benefit to the condition. So it's not ranking them in order, it's just classifying them. So in the classification here, you really only have 5 classes of drugs. So the first 3, these are the gabapentinoids or alpha-2 delta ligands. These are all strongly recommended. The next 4 are all iron, one of which made a strong recommendation, and then 3 are conditionally recommended. Conditional means in certain situations and not as strong research evidence, but still recommended. And then the 3 areas we'll talk about today. One is dipyridamole, one is perineal nerve stimulation, and one are opioids, which we know work probably better than all treatments, but they have more risks, so they're not as strongly recommended, of course, and there's actually less research on opioids than on some of these other treatments. But we're going to look in at some of these because these are technically somewhat experimental to some extent. That doesn't mean that these are ranked in order. This just means they're in a general class where the benefits of these treatments outweigh the risks. Other drugs you may be familiar with that are not on here, the risks outweigh the benefits. So those should not be used except, in very specific rare circumstances. So let's go to opioids first. So buprenorphine's hard to pronounce, but that's how it's pronounced. Buprenorphine makes a lot of sense as an opioid for restless leg syndrome. So what is it? So it's a narcotic pain medication. So it's like, in some ways, it's like all other opioids. It's a pain medication. And what happens is the unique nature of it is it partially stimulates the opioid receptor. So we'll be talking a lot about receptors today, but they're basically kind of like shipping ports in the brain where one chemical goes to the shipping port and it sends a signal to the brain cell. So the opioid system is highly involved in restless leg syndrome. There might be deficiencies in the opioid system. So opioids are not only the oldest treatment for restless legs dating back to the 17th century, they're also one of the most powerful treatments we have. And it's not the effect that we're worried about, it's more the risks of opioids that we're worried about. We know they work extremely well. So buprenorphine, because it's a partial, it's a complex chemical process, but the fact is buprenorphine does not affect breathing like the other opioids, meaning you take your whole bottle of buprenorphine and you swallow the whole thing. It doesn't work if you swallow it, but if you take the whole thing, you're not going to die from it because you stop breathing. That's why we have opioid-related deaths, because opioids cause people to stop breathing if they take too much. Fentanyl is a powerful opioid that if somebody takes too much of it, they could be dead within minutes. Buprenorphine will not do that. So it's the safest of all opioids. Long half-life. So that means that the drug lasts a long time. So it's smooth in and smooth out. It's not a big up and down effect like a roller coaster when people take it. And because of that partial opioid effect, it doesn't cause what we call euphoria or people to get high. So people are very less likely to abuse buprenorphine, and that's why it's used for drug abuse. So it's FDA approved for pain or for opioid use disorder, people who abuse or have problems with opioids, because it's much safer and people are unlikely to abuse it. So it sounds like a great thing. So my group had published an abstract at the National Sleep Conference almost 2 years ago. And unfortunately, I'm here giving a webinar and I could be at some point writing this up, but it's taking me a while. I just need to write it up and submit it. So this will be a paper hopefully this year, but I said that last year, so don't hold me to it. But it's a big study, relative to the number of studies I'm going to show you that are not big. But let's go through the study because this is important information. This is the drug that most of the audience or people people in the audience who have people they know are more likely to be on buprenorphine than any of the other treatments in this lecture today. So this was a study of 55 people over 1.5 years. So it's what we call a longitudinal study. And it was a restless leg specialist who may or may not be speaking right now, and then a nurse practitioner who worked with him. And it looked at a bunch of things, restless leg severity, sleepiness, health, insomnia, mental health. So it looked at a lot of factors, not just restless leg syndrome. And it turned out that most of the individuals had severe restless leg syndrome and had augmentation from dopamine agonists. And 37 of these 55 people were on buprenorphine, and 30 of the 37 with augmentation and on a dopamine agonist were able to discontinue their dopamine agonist. So 4 out of 5 discontinued it on buprenorphine. 5 out of the 37 were on the way to discontinuing it at the end of the study, and only 2 had no change, and they might have been in the process. We don't know where they were in the process, but the majority of people had a dramatic benefit from the drug in terms of getting off dopamine agonists. So this chart, this shows the range of the restless legs scores, the international restless leg scores. So as a reference, if those of you who aren't familiar with this, 20 and above is severe, 30 and above is very severe. So the average individual in this study was almost in the very severe range, and after 6 weeks, all the way out to 1 year, was down to the low moderate range on buprenorphine. The clinical global impression scale, This is the number of individuals who were very improved or much improved. And it was almost everyone at 6 weeks, 3 months, 6 months, 1 year. Almost everyone who stayed on the drug was improved. And at the final visit, 76% were able to tolerate the drug, and about a quarter or so, less than a quarter, discontinued the medication due to potential adverse effects. And that's pretty good, for most drugs that are this powerful. And 53%, so almost half, it was actually in the first few weeks that they discontinued. So once people tolerate the drug, they tend to stay on it and not have issues later on. All of these areas improved: sleepiness, insomnia, mental health, sleep disturbance, physical health. All of these domains improved statistically in a statistically significant trend for 1 year. And so I present these ideas. Those of you who have seen this before, know I've talked about this, but I propose that this might be the first opioid used for most patients who need opioids because of the relative safety, the effectiveness. This is potentially a go-to drug for opioids. It's DEA Scheduled 3, so that means, yes, you can get refills. Yes, you can get a 90-day supply. And yes, you don't need to see me in person because I can't see you in person anyway. I don't have a clinic to see you in person. And the people in Florida don't want to see me in person. They don't want to come all the way up to Michigan where it's 25 degrees. So no in-person visit, that's huge. So that's a huge difference with the drugs, say like methadone or oxycodone, where you can't get refills, you can't get more than 30 days, you got to see somebody once or twice a year. It's a huge hassle reduction, both for a physician and for an individual with restless legs. The 3 common forms that are prescribed are going to be Suboxone is the brand name, but it's buprenorphine naloxone. The naloxone is not absorbed or effective. It's just an abuse deterrent, so it's irrelevant to the treatment. But the lowest strength film is too strong for most people. So people are actually going to start off on an eighth of a film, and then it builds up over 5 days, and then it's adjusted every 5 days. The more practical one is the buccal film called Belbuca. This one is more expensive though, and people can start with the lowest strength film or half of it. And then the Butrans patch, which is a patch worn for 7 days a week, getting a steady level of the drug for 24 hours a day, 7 days a week, until the patch is switched after 7 days. This has a generic form, and I've had a lot of success recently with Medicare approvals, especially the generic form of the Butrans. So this may be a good option. This is a very low strength form, which works better for people with restless legs. So what are the adverse effects of buprenorphine? Similar to other opioids, perhaps less so because of the unique chemical properties. But your nausea might happen at first, or if people get constipation, the nausea can be caused by constipation as well. If the drug is too strong, it can cause dizziness and unsteadiness or impairment, but usually the dose has to be adjusted to avoid those things. With the sublingual and buccal film, there is a slight increased risk of dental problems, not well understood, but that's a concern. And then obviously for any patch, there could be skin irritation and problems. And then there are also some concerns about a condition called mild central sleep apnea. It's a different type of sleep apnea than obstructive sleep apnea, which it happens more in standard opioids like methadone or oxycodone. But it may happen even with buprenorphine at very high doses, probably not going to be used in very high doses for restless leg syndrome. But the mild central sleep apnea may not be significant in any way. It's just something that might pop up on a sleep study. So the drawbacks of the drug are that it's a long-acting drug, so therefore the adverse effects could be long-acting. Somebody taking a short-acting opioid like codeine, oxycodone, if they're having adverse effects, the drug's out of the system within a few hours, so then that goes away overnight. So that's one of the drawbacks. As I mentioned, the buccal film and the patch costs more than the sublingual film. And then lack of insurance coverage, of course, can be a barrier if people can't afford to buy the medication. But again, as I mentioned, Suboxone and the generic form of the Butrans patch are frequently covered by insurance. And that's what the film looks like. And imagine cutting this into 8 or 16, pieces and trying to take it. It's hard. So that's why these lower strength forms might be more practical. The other issue is the medical establishment is unfamiliar with the drug. So a lot of doctors don't even know they're allowed to prescribe it. Some doctors think because it's used for opioid use problem, people with opioid use disorder, they think it's a dangerous drug, when paradoxically, it's actually safer than all the other opioids, which is why the DEA has less regulation on it. But doctors actually don't know this. They think it's a deadly drug. And it's just the opposite of what they think. So people run into barriers if they ask for it, because most doctors are actually not very familiar with this drug, even though it's used a lot by certain groups of physicians. So we're going to move on to perineal nerve stimulation. This is probably the number two, experimental treatment that people want to know about. And this one is the newest treatment that's, kind of come into the mainstream. So what it is, it's a high frequency nerve stimulator. So what it is, it's a cuff that's worn below the legs, so it's not implanted in the legs. And it's what it's described as doing is it creates this tonic motor activation, basically meaning the leg muscles are that are down in the lower part of the leg. The perineal nerve kind of comes up through the knee, and it stimulates that nerve, but it activates the muscles below the knee, almost like one would be walking without having to walk. So it's a great thing. You don't have to get out of bed, walk around. The device is sort of walking the muscles for you. They don't actually move, but it's almost like they're being activated. Now, some people had questions as to what is this called. So this is the brand name of the device now, called the Nidra. And it used to be called the NTX 100 Tomac system, if you've seen that terminology. This is all the same device. Perineal nerve, fibular nerve stimulation, same thing. All of these are the same thing. So the original study was Dr. Buchführer, who's on the part of the RLS Foundation Medical Advisory Board. But 37 subjects with moderate to severe restless legs were tested for 14 days. Now, this was a randomized controlled trial. So some people got a fake stimulator, and then some people got the real stimulator. And the International Restless Leg Scale, that scale I showed you earlier in the buprenorphine study, went from 6.4 versus only a 3.4 point improvement for the sham. So this was the American Academy of Sleep Medicine Task Force felt that this was a clinically significant difference of this 3.4 points was clinically significant. And given the low risk of adverse effects from the device, that's beneficial. It's beneficial to the condition based on this study. The second study was another randomized trial. So this one was 4 weeks of the randomized trial, and then everybody was put into the device in the last 4 weeks where they knew they were getting the treatment. And that responder rate of much or very much improved, it was 45% versus only 16% with the sham treatment. So quite effective in a lot of people compared to the sham device. So these are the two major studies that got the conditional recommendation by the AASM. I wanted to highlight one additional study. It was not a randomized trial, but this one was from Roy and others on this topic, and it was 103 subjects. And what they did was they took those the people in the 8-week study, and they put it out, kept them on the machine for 24 weeks versus another half who were put on nothing for 24 weeks. And again, the responder rate, those who are on the device for I guess it would have been the 32 weeks, 73% reported much or very much improved restless legs, whereas only 13% were improved who weren't getting any treatment at that point. So this was another nice longer term study. We obviously don't have year or 2-year studies yet, but initially this was very good. And then one last one, we talked about opioids, but Dr. Buchführer did a study that he led on 20 individuals who were already on low dose opioids for restless legs. And 70%, they went through a treatment protocol with the device, and 70% were able to reduce their opioid dose by at least 20%. So that was in some more and some less. So it was a proof that it is having an additional effect to the drug such that you didn't need to use as much of the strong drug as was required originally. So this was a good concept. So what are the details here that are important? So first of all, it's a low risk treatment, unlikely to have any moderate to severe side effects. It's available in several US states, but not all of them. They they have to get approval in each state. So that's the biggest barrier, is you may not be in a state where it's available yet, but it eventually will be available everywhere. And the good news is last fall, they got CMS reimbursement codes. So the Centers for Medicare and Medicaid have a code. So it's now more likely to be approved. And it better be approved because the device is very expensive. So most people choose to go through insurance for this one. This is not a cheap device. So dipyridamole. So this is the third sort of more investigational drug from the ASM guidelines that I'm going over. So these are the three that you're going to see the most. Dipyridamole, it's an antiplatelet drug. It's a drug that prevents blood clotting. And why would it work for restless legs? It stimulates adenosine in the brain. Adenosine, maybe a lot of basic science studies have shown that adenosine system in the brain is a little bit underactive. So by stimulating it, it may improve symptoms of restless legs. You all know about adenosine because most of you drink caffeine or consume caffeine. Caffeine works by blocking adenosine in the brain. Adenosine makes people sleepy. Caffeine blocks it, wakes people up. So that kind of makes sense. And that's why that's why caffeine may make restless legs worse in a lot of individuals. So unfortunately, there was only one randomized controlled trial of only 2 weeks. So the results were very good, though. But again, it's a 2-week study, 28 individuals, and these were not treated and not augmented. So it's not people on 20 milligrams of ropinirole or 15 or 5 milligrams of pramipexole. These are people who aren't on any drugs and they weren't augmented. So it may not apply to all situations, but the results were very good. The improvement of placebo was only 5 points, but those who got the actual drug improved by 13 points, which is a pretty strong amount of improvement. And the average effective dose was 218, which is a fairly high dose of this drug. In the US, dipyridamole is still available. It comes in 75 milligram tablets, and it's generally prescribed anywhere from, I guess, 75 up to 300. These are the main adverse effects: bloating, dizziness, fatigue, and headaches. From my experience, the headaches tend to go away after several days, whereas some of this other stuff may or may not go away, but these are factors to consider. And then if someone were to start on dipyridamole, it's not a controlled substance, so it's not that easy to get because it's an older drug, but it's not regulated strongly. And got to be careful with other drugs that prevent blood clots: Plavix, Coumadin, aspirin, anticoagulants, because this can maybe thin the blood a little bit. So we're going to move on to drug treatments that are going to be progressively less common, but still more investigational. Magnesium. The problem with magnesium is that it's mostly confused as a treatment for nighttime leg cramps. That's where it's really been noted. I don't know when people say it works for their legs, if it's really restless legs or not. And that's what you might see on the internet or on videos and things. But there is some basic science that shows that it might enhance the opioid system, so maybe it could work that way. And then recently there's been some discussion of, does it reduce brain excitability? Not that you're excited, emotionally excited, but the excitability of the nervous system. Think of preeclampsia. Magnesium is given to women who are pregnant and who have preeclampsia to prevent a seizure, which is an overexcited brain, basically. So it works as a seizure prevention. Maybe it works to prevent the symptoms of restless legs. The one kind of decent study that is available right now is an open label study, meaning everyone knew they were on the treatment. And it was only 12 individuals for 12 weeks. They got magnesium citrate, 200 milligrams, and the International Restless Leg Score improved by 6.7 points. Other than this study, there is not a lot of good science out there on magnesium, and it might be something to investigate, but the proof is not there yet. So be careful when people recommend magnesium. It might not be the right condition and it may not work. So this one is definitely in kind of this investigational category. Okay, so let's talk about acapapam. So it's a D1 receptor blocker, and I'll show you this. It'll make more sense in a second. But one of the problems with restless leg syndrome may be the dopamine system. The problem with dopamine agonist is it screws up the dopamine system. So one of the things that gets screwed up is this D1 receptor. And guess what? Acapapam blocks the D1 receptor. So it sounds like a good idea. So it's actually an experimental drug. It's in phase 3 trial for Tourette syndrome. And from my understanding, it's going to be approved for Tourette syndrome, which means it will be available off label for restless leg syndrome. I last looked, it's not available yet. It hasn't been approved yet, so it's not available yet, but to be uh, available potentially for use in people off label. So this is kind of those of you who have seen my other webinars, which I would encourage you to go back and watch some of these if you want to learn more. But these are the dopamine receptors, and this is the natural dopamine, these triangles, and these, I don't know, moons are the dopamine agonists. They bind to the dopamine receptors, and they create a cascade of effects that relieve restless leg syndrome. Except in augmentation, these receptors start to degenerate and it produces less and less relief of symptoms. And then as the augmentation gets worse, there are fewer D3 receptors that relieve restless legs, and there's a lot of D1 going on that actually makes restless legs worse. This is where acapapam works. It blocks this bad guy receptor that's making things worse. And that's the theory of how it would work for restless leg syndrome. So Dr. Ando at Houston Methodist did a study in 2020, very small study. He took 7 subjects. They were all augmented on dopamine agonists. So they were continued on the dopamine. He didn't take them off the dopamine agonist. He just kept them on the dopamine agonist and then added acapapam. And it was a crossover trial. So half the group got the drug, and then the next half of the study, they got switched from drug to placebo. And each arm of the study was 5 weeks with 2 weeks of washout in between. No one discontinued the drug. Drowsiness was the main adverse effect. And the International Restless Leg Score improved almost double, 4.6 points versus 2.4 points compared to placebo. But the authors noted that there was issues with crossover because there was maybe a lingering effect from the drug in the placebo part because the drug might have lasted longer than the washout. Anyway, it's just a proof of concept, but this really deserves more investigation, and maybe it will once it's approved for Tourette syndrome. But there's at least some principle here about it. The issues are, what is the interest of the company? According to Dr. Ando, the company has no interest in restless leg syndrome, which is mind-boggling because it's, I think, 5 times more common than Tourette syndrome. But we'll have to see about that. We don't know what the cost is. Is this a $10,000 drug? I mean, who knows? So we don't know if we're even going to be able to use it off-label. And then there's suspicions of what are you getting when you get this drug? What is it going to do to the dopamine system with long-term use? And that's a huge concern because we saw what happens with dopamine agonists screwing things up long-term. What is acapapam going to do? Even if it is good at the beginning, is it a good long-term treatment, or are we just going to use it in the short term? So to be determined. Perampanel. So perampanel is a seizure drug. The brand name is called Fycompa. It's a drug used for epilepsy, and it blocks an AMPA receptor. So we talked a lot about receptors. AMPA is a receptor that transmits glutamate. Yes, like monosodium glutamate. Unfortunately, it's the glutamate in the brain, not that you eat. But glutamate actually is a stimulatory chemical in the brain. GABA is a slowing down chemical. Glutamate is like it's a yin and yang. GABA slows things down, glutamate speeds things up. So if glutamate is overactive, that's how a seizure will develop. But we also think glutamate is strongly involved in restless legs. It's the overexcitation of the glutamate that might be transmitting that urge to move or those leg movements. And so again, Dr. Garcia Borriguero in Spain, he's got a lot of time in Spain to investigate drugs apparently, but he took 20 subjects who were untreated again, and he did an 8-week open label trial, meaning everyone got the drug and knew they were getting it. So there's some bias and placebo effect involved. And they got the lowest 2 doses between 2 and 4 milligrams. And 12 of the 20 subjects improved by over 50%, and then 4 out of the 12 had partial improvement. Dizziness, sleepiness, headache, irritability were the main reported adverse effects in this study. And I do want to say, I think there actually is a black box warning on this drug because of agitation and behavioral issues. I think I might have another slide on that later, which I do. So I'll touch base on that in a second. The other interesting thing that came out last year, if you guys read, I did a little summary of this in the news and Nightwalkers, is that there was a massive, massive genetic study that came out last year by the other Dr. Winkelmann, the one in Germany, not Dr. Winkelmann at Harvard, but they found that the genetics had suggested the genetics in restless legs that the brain might be sensitive to treatment at these glutamate receptors. And they even pinpointed perampanel as one of the drugs that seemed to fit with the genetic types of response that they did, which genes predicted which types of drugs might work. So they cited perampanel. So we're kind of a little bit excited about it, but we're not so excited about the cost of the drug. So the cost is, according to the database I looked up, it's $25 for a 2 milligram. It's actually like $50 per tab of 4 milligrams. So needless to say, there are no randomized controlled trials of this in the US or anywhere for restless legs. And so the cost is an issue. I have not had one individual on this drug yet, but it sounds like a good option. And again, there's a black box warning for psychiatric and behavioral reactions. Doesn't mean everybody's going to get it, but that's a concern because if you block certain areas of the brain, it could cause these behaviors to come out that otherwise would be filtered out by the brain. And so let's move to spinal cord stimulation. We're down to 2 more investigational drugs. So spinal cord stimulation, this is an example. There's a little generator that's in the back, like usually in the buttocks, and it's wired up into the middle of the spine. And the spine just gives some stimulation, and that is thought, maybe similar to the perineal nerve stimulator, gives feedback to the brain, like to shut off the pain system. It tries to shut off the restless leg syndrome. The spinal cord gives feedback to the brain shuts off the restless legs. That's the theory of how it might work. So Diego Carvalho at Mayo Clinic, so this was just an abstract. He was actually sitting his abstract was next to mine on buprenorphine. And I discussed this with him, and his group found 16 case reports in case series. 14 of them, they had a spinal cord stimulator for chronic pain, which is what it's indicated for. But all of the patients at one point had restless leg syndrome improvement from the stimulator, even though it wasn't for restless legs. A couple of them, it was for restless legs, and 2 of the ones where it was treatment just for restless legs, it seemed to not work as well over time. And they had the stimulator just kind of removed. They had a temporary one in and they had it removed. So we don't know how it might work long term. So maybe that feedback loop goes away after a while. But this is a potential option. And there's other forms of spinal cord stimulation that aren't, sticking something into the spine or implanting a device. There are other external forms that are starting to be looked at where it could be applied to the outside of the back and stimulate the spinal cord. So that could be an area that's going to come under investigation very soon. Lastly, we got cannabis. So cannabis, what do we do with this? There is, unsurprisingly, not a lot of research in restless leg syndrome, but the big study was a study of 18 people. And it was a randomized trial. It was individuals with Parkinson's disease and restless leg syndrome. And they were put on CBD. This was a study from 2 years ago. And unfortunately, they found no difference in placebo for any of the outcomes that they were measuring. So we call it a negative study. It didn't show that there was any benefit to the CBD. So when we think of cannabis, most of the stories we hear are what we call anecdotal evidence. You might hear of somebody who had a benefit. But right now, it's untested. It's not even investigational yet. We don't know anything about it, really. We don't know how it works. Does it help with sleep? Does it help with anxiety? Is it a placebo effect? We don't know how it works. If it works for restless legs, we don't know how to take it. Is it vaped? Is it a cream? Is it put in food? Is it a gummy? We don't know. How much do you take? 2 milligrams, 10 milligrams of what? THC, CBD? What are the long-term effects? Does it work for 6 months and then it doesn't work? The problem is the DEA has scheduled it as Schedule 1, meaning there's no medical use for it, even though it's used medically more than any of the stuff that I've shown you today. but the DEA needs to deschedule this so it's easier to do research. The only research trial I could find that might be ongoing is in Sarasota, and it's on a chylobinoid, which is a combination of cannabidiolic acid with a little bit of magnesium and CBD. And it's a cream. And in this study, it's 30 to 45 minutes before bed. They apply the cream to the legs. Doesn't really say exactly how much, but it's going to be for 2 weeks. And then they're going to look at the effect on the restless leg scale and then quality of life. So we'll at least get some idea. Unfortunately, it's not a randomized trial with fake magnesium cream or something, but hey, at least there's a trial that's active. So you can go to clinicaltrials.gov. There's not a lot to see there, unfortunately. So that's kind of the downside, is we've got some good stuff here, but there wasn't an overwhelming amount of clinical trials going on in restless leg syndrome. So this is the stuff I pulled up. Kind of excited. There's a European trial on D-methadone. It's just a chemically altered form of methadone, probably, because there's some drug company that's making it that's going to support it. But that's exciting because we need a clinical trial of methadone. Pitolisant is a newer wake-promoting drug, and suvorexant is a sleep-promoting drug. So it's interesting that these are both being tried. Vitamin D, magnesium citrate, and then interestingly, gabapentin and acarbol in adolescents. So this is good news because there are no drugs that have really been studied in children. So we do need trials of that. And then non-medication studies, so Buddhist walking meditation in those with end-stage renal disease, a combination of kinesiotaping versus and lymph drainage in pregnant women. That's an ongoing study. And then stretching versus physical therapy. That's another study. And then dry needling with electrical stimulation. Some people have asked me about this. So there actually is an ongoing study. Again, different phases of these studies. So I don't know what's active and what's hasn't been started yet. But these are the ones listed on the clinicaltrials.gov website that maybe a future lecture we can go over. So we will have a few minutes for questions. I think I was able to get 10 minutes. If you have questions for me after the lecture or in the future, I'm the founder of Relax Health, and I serve, soon to be 5 states in the US through telemedicine. But I do produce a lot of educational material, including a blog on my website. And then I have a YouTube channel with at least 50 videos on restless leg syndrome. There's a whole folder of restless legs videos you can watch. They're all about 5 to 10 minutes. So you could watch them in 250 minutes in the next 250 minutes for the rest of the night. And then I will move on for 10 minutes of questions. So I'll turn it over to Adriana for questions.
Hi, Dr. Berkowski. Thank you so much for your presentation and for the effort that you put in to help simplify such complex concepts. So for those who registered in advance, you can submit a question. And so we pull those questions and we try to answer as many as possible, which we have about 10 minutes to do so. We're just going to start with some general questions. Can a medication that is not approved for RLS still be safe?
So yes, so hopefully the lecture answered this question in that pretty much nothing that's been approved for restless leg syndrome is being used, and everything that's being used is not approved. So again, the safety, most drugs that are FDA approved are approved for safety first and foremost. So if the drug's FDA approved, that's a good sign that it's going to be a safe drug. The problem is you get into situations like with Parkinson's disease drugs, is that people are getting put on Parkinson's doses of Parkinson's drugs that were never intended for restless legs because they're the same drug. So that's a big concern in some ways, but in general, these drugs are proven to be safe if they've gotten FDA approved in the first place. But it really is going to depend on our using them in clinical studies in restless leg syndrome. And that's really the key thing to note, is have they been tested in this condition rather than whether they're approved or not approved.
So if a medication is not FDA approved for RLS, does that mean it is not as effective for RLS?
Right. So it means, it doesn't mean anything. It just basically means that it's not been tested for FDA approval for restless legs. But again, our most effective drugs are these gabapentinoid drugs, all but one of which has never been FDA approved. All the opioids have not been FDA approved. So again, focus on just the research studies in restless legs more so than the FDA part of it.
If my provider recommends treatment using a medication that is not FDA approved for RLS, how do you recommend checking possible drug interactions and other safety measures for use as a patient?
So that would fall in the area that, like, I don't know that you as a patient or somebody like a loved one should be doing that. That really, the doctor should be aware of these drug interactions when they prescribe it. And sometimes it gets flagged uh, when it's prescribed in these electronic systems. But the main thing is to, again, look for guidelines like the RLS Foundation algorithm, which we're going to be updating hopefully soon, and the ASM guidelines, and just different publications on restless legs and how the drug is used in that condition when, because again, 5 milligrams of pramipexole is for Parkinson's disease. It was not approved for restless legs. Shouldn't be used at that dose, but you have to read the restless legs literature to know what the dosing is. So that's kind of the most extreme example is the Parkinson's to restless legs thing. But for these other drugs, you're not using epilepsy doses of perampanel or pregabalin or gabapentin. You're using restless legs doses. So that's the important thing, is to look at what is being used for the condition.
So is FDA approval for treatment only related to insurance?
It has actually nothing to do with insurance, but the insurance is much more likely to follow. And well, I shouldn't even say that, because with gabapentin and acarbal, it's hardly ever covered by insurance, and it's the only FDA approved drug. But yes, theoretically, if it's FDA approved, it's more likely to be covered by insurance because there's a high level of evidence to support its use. But they still can hide behind other drugs and other generic forms of drugs when they want to not pay for something. So it really is unrelated to the FDA process.
On that same wavelength, opioids are approved by the FDA and they are primarily prescribed for pain management. So when opioids are used to treat RLS, is it simply addressing the pain, or is the mechanism different?
So as I mentioned, the mechanism is a little bit different because restless legs, it actually counts as a chronic pain condition, but it's not, for 80% of people, it's not actually painful. It's uncomfortable, but it's working through that opioid system in some similar ways to how it would work for pain. But there are some major differences. The two biggest ones being it's much more effective at very low doses. And then it's a lot people tend to not need more and more opioids with restless legs. People don't build up a tolerance as much to opioids like they do for chronic pain, where people, can end up taking more and more and more. And that's why it's fallen out of favor for chronic pain.
So this is a very common question that we get, and you addressed this, but we just want to clarify. Is the NTX 100 tonic motor activation, or TOMAC system, the same thing as the Nidra device?
Yes, so I think that's what it was called before the brand name came out, and that's what it's called in the FDA approval paperwork. So the NTX 100 TOMAC is the Nidra brand name device. Now there could be, I don't know, when the patent runs out, there could be a new device 8 years from now if somebody's watching this webinar, and there could be some other device. But yes, so right now they're one and the same. It's a kind of a unique technology.
Is the TOMAC slash Nidra device the same thing as a TENS unit, TENS?
Yeah, I didn't mention that. This is high frequency stimulation. TENS units are lower frequency. And the TENS unit, if somebody's had a TENS unit applied to them for physical therapy or something, it's a little bit too powerful or strong that you could fall asleep with it. Whereas the people who did research and developed this device felt that this high frequency was comfortable enough that you could actually have it running and then you would fall asleep with it and it wouldn't wake you up or keep you awake. So I think that's what they cited as why they used a much higher frequency here. But in some ways, it's a similar idea. And I had people try to use TENS units, but like, rig up their own perineal nerve TENS unit. But this really is designed for this purpose, to fall asleep with it on and it possibly running.
Have you seen results with alternative treatments such as dry needling, Botox, or ketamine?
So I mentioned the dry needling study. We really don't have any research yet on it, so hopefully that study will come out. Botox, there might have been some case reports. That one might be investigated just because Botox is widely available. We don't have enough to make any, statement on like where, what muscles or where do you get the Botox. So that's really early stage theoretical treatment. The ketamine is very interesting. Ketamine used to be one of these banned drugs like cannabis technically, and now it's being used mostly for depression, PTSD, some mental health conditions. But ketamine is an anti-NMDA, so it's another chemical blocking drug. And actually, it's possible that methadone and maybe buprenorphine have a little bit of anti-NMDA properties in them. So it was theorized that maybe this anti-NMDA might help with restless legs. The problem is, well, we don't have any studies yet, but from my experience, I've had several patients have it for depression or other conditions, and they haven't noticed a benefit to the restless legs. So unfortunately, where I've seen people with the Nidra device or the perineal nerve stimulator have a benefit, I've seen it. I've seen people with dipyridamole, not a lot, have benefit from dipyridamole. I haven't seen anyone have benefit from ketamine. But it really could be studied, though, as it's becoming more widely studied in other healthcare areas.
Great. And then this will be our last question of
All
the
right.
night. Is there any research being done specifically on the relationship between the gut microbiome and RLS?
So this is a great question. I didn't talk about it today because the big study, one is that the gut microbiome is going to be a huge area, especially some of these initiatives of the people getting hired into these power positions are going to investigate the gut microbiome. So this could be an area of next 10 years of emerging research, including in restless legs. But we already see it in a condition called SIBO, which is small intestinal bacterial overgrowth. And there was a trial in SIBO of a drug called rifaximin, which is an antibiotic, as well as naltrexone, low-dose naltrexone, which is actually an opioid blocker, but it was a low dose, so it actually stimulates the opioid system. So they used this combination in people with SIBO, and a lot of people with restless legs actually got better. And SIBO is one of those gut microbiome conditions. And so there was a proof there, some proof of concept that if we fix the gut bacterial system, it actually had a downstream effect on restless leg syndrome. So that's an area of ongoing investigation, but it's still kind of preliminary. The whole gut microbiome, there's going to be stuff on it. There's just not much on it other than that rifaximin and low-dose naltrexone study in SIBO. But other than that, we haven't had direct studies of altering the gut microbiome for restless leg syndrome. But I'm sure there's a big connection there, but it's yet to be investigated very well.
All right. Well, thank you so much for joining us tonight. And thank you so much to our audience for joining us for today's webinar. We hope to see you on Wednesday, March 26th for our next webinar with Dr. William Ondo, titled Case Studies, Advanced Management Strategies for Severe RLS. And to register, you can visit our website, www.rls.org. Thank you again and enjoy the rest of your night.